called woke. It seems like one of Barbara's governors can't say anything other than woke. And I'm not sure that we should let those people hijack what it really is. I'd like to have a show on that in the future, if you agree. But let's move to our current speaker and the exciting topic of what she does. And Dr. Nabert, I'm going to let you have the honor of introducing her.
Thank
Sam,
you so
can you
much.
show the slides? Can you put up the first slide while Dr. Nabert introduces her?
Oh, my slide. Okay.
No, I want Simon to put them up. I have a special
Okay.
slide for you.
So our special guest today is Dr. Renee Bovell, and she came highly recommended to us from one of our regular viewers, Dr. Alice Coombs. And I am so happy that she directed me into the path of Dr. Bovell. She is such an exciting person doing exciting things, and is an example of how diverse our expertise is. I don't think people have any idea how diverse our expertise is. Dr. Bovell, who is a native of Washington, D.C., is the owner and medical director of Advanced Eye Care Medical Center, doing business as Envision Eye Laser. She is a board certified ophthalmologist and has received training at Wellesley College, UCLA School of Medicine, Yale University, and the LSU Eye Center. But just to show you that even ophthalmology is a very difficult specialty to get into. So besides breaking into that, she has a master's in cybersecurity, strategy, and information management from George Washington University, which focused on policies and practices that protect critical information with particular attention to the healthcare field. And my goodness, with us moving into this whole AI world, this kind of expertise is certainly needed, and she continues to share her expertise in many venues and organizations. Without further ado, one other thing I want to point out about Dr. Bovell. Dr. Bovell was recognized as Maryland State Medical Association she has been recognized by the Maryland State Medical Association and has been named ophthalmic, world leaders, OWL.
Yes.
And most recently has been inducted into the 2023 class of Enterprising Women of the Year. So you can see we are really blessed with a very talented speaker today. And without further ado, I turn it over to Dr. Bovell.
Thank you both, Dr. Maxey and Dr. Nabert Stevens, for that wonderful introduction. And yes, ophthalmology, ophthalmic, all the O's, it's definitely a tongue twister. So what I'd like to do today is talk with all of you and tell you why your eyes are the windows to your health. So I'm going to start screen sharing, if that is okay. All righty, good. So everyone can see the screen?
Yes.
Yes, thank you.
Okay, great. Okay, so what I'd like people to know is that most older people have good vision. A lot of us think that as time passes, that our vision is supposed to deteriorate, and really it should not. And just as in the rest of medication, medicine. If you have a problem, see your ophthalmologist, because most common problems are treatable if we find them and catch them early enough. First, what I'd like to go into is give you an overview of ophthalmology, a little bit of our language. What does 20/20 vision mean? Well, that's how we measure visual acuity. And we measure it in terms of how far you are away from the target. And the standard is being 20 feet away. So there's a certain line of vision right here. This right under this red line here is marking the 20/20 line. And we make that the standard that people should be able to see that line if they're 20 feet away. Now, if somebody, let's say, has poor vision, they might need to be closer. So that person, if a person with 20/70 vision, who is 20 feet from the chart, sees what an unimpaired person can see from 70 feet away, that means that person has 20/70 vision. So they don't see as well. I just wanted to clear that up. Now, on the other hand, if somebody has 20/15 vision, that means that they see better than the average person. So someone who is 20/15 or even 20/10 can see better than someone who has 20/20 vision. So what are some of the normal changes of aging? Need for reading glasses is normal, changing eyeglasses. Sometimes the eyes can become more irritated, or you may have to rub them more, and the eyelids and external tissues can change. I'm going to start with showing the anatomy of the eye, just so that we're all on the same page. This is a cross section, and this is looking straight on at the eye. Right here is the cornea. The cornea is the clear window of the eye. And actually, people who wear contact lenses, when they put the contact lens on their eye, they're actually touching the cornea. Then there's a space that's filled with fluid. And next, there is the iris. The iris is what makes the eye brown, green, or blue. And there's always a hole in the iris. That is the pupil. And you can see here, the iris comes down, and there's a space, and then here it is again. Behind the iris is the lens. That's what helps us to focus, so that when we read up close, the lens goes into a ball. When we look further away, it flattens out. Next, we have this posterior chamber, which is filled with a jelly-like substance. And all around this wall, which is the sclera, is the retina. That's akin to the film in the camera. And then we have the optic nerve. And the optic nerve connects the eyeball to the brain. Some things you can see in the eye without a microscope. If you look at your eye and you're under 50 and you have a heavy white ring like this, that could be a sign of high cholesterol. As time passes, people in their 70s, 80s, we tend to see this and it's not as alarming. But if you have this white ring and it's earlier, then you should ask your primary care doctor to check you for cholesterol, but it does not harm your vision. Next, I'd like to talk about tears. Especially now, after COVID, we've been wearing our masks, and we're on computers more, we're working from home, we're on Zoom, and you may find that you're rubbing your eyes a lot, that your eyes don't feel as good, you may find yourself tearing. Well, that may be that you're not creating the right kinds of tears. Now, we don't need to go into all of these, but this is just to let you know, tears have a lot of active electrolytes, proteins, things that protect you against bacteria. And if your tear film is not healthy, that puts you at risk for infection, scratchiness, and things like that. So we want to make sure you have a healthy tear film. And what we may call it dry eye, but really it's dysfunctional tear film. And this occurs as people increase in age. It's common in postmenopausal women. It's also common in people with autoimmune disorders such as Sjogren's or lupus or even rheumatoid arthritis, and even certain medications can predispose us to this. Now, that doesn't mean that you should not take your medications. It just means that we need to work with you on this. And if you wear contact lenses and you realize that it's harder for you to wear your contact lenses, you're having trouble seeing, you're rubbing your eyes, that may be a sign of dry eye. And especially here, smokers. We all know that smoking is not good for our health. And that's any kind of smoking. Really, the only thing that should be in our lungs is air or a medication if you have to take like an inhaler or something. But any kind of tobacco smoke is not good for us. Sometimes when you look at people, you may see, or even if you look in the mirror, you may see a growth coming across the eye. That is called a pterygium. Sometimes we call it by its common name, surfer's eye. And it's caused by irritation, dust, not wearing sunglasses. And if it continues to grow all the way across, it can be vision threatening. So we remove it surgically. This is a pinguecula. It just hasn't, it's similar to a pterygium, but just hasn't gone across the cornea yet. As I mentioned, rheumatoid arthritis, which is very common, that also has ocular manifestations, including dry eyes, redness, which is episcleritis or scleritis. It can lead to corneal ulcers or even inflammation inside the eye, which we call uveitis. So I caution you just to remember, if your eyes feel irritated, feel sensitive to light, don't wait. Try to see the ophthalmologist sooner rather than later. And this is, you see, this is in one sector here and over here as well. This is someone who has rheumatoid arthritis and they have episcleritis. And this is something that can be treated. Most recently, you may have been hearing about thyroid disease. And thyroid can cause eye problems. And you may remember one of the most common pictures that we see. Remember when Barbara Bush had thyroid eye disease, her eyes were opened very big, they were red. Sometimes people don't have any signs or symptoms, and sometimes people feel that it's irritating, it's red, it causes blurry vision, and it can be very uncomfortable. This is what it looks like. And we can see, normally, we don't see, when you look at someone, you don't see the white part of the eye up here. And you also don't see this amount of swelling. So if you have that, again, there are things that we can do, there are medications we can prescribe to help you with this. Now, I'd like to talk about glaucoma. glaucoma is very common and very prevalent in Africans and African Americans. And some of the risk factors include increasing age. Asians have a certain kind of glaucoma, and you have to talk to your family. See if your parents, your brothers and sisters, or your grandparents, aunt and uncles have glaucoma, because it does travel in families. The modifiable thing that we can change in glaucoma is intraocular pressure. And what happens in glaucoma is there's pressure here. Remember I said that earlier, this is filled with water, this is filled with a jelly-like substance. If this water, we call it aqueous humor, and it filters out through here, if there's too much pressure here, it reflects back to the optic nerve and causes damage. And there are ways we can treat this so that it doesn't cause damage. But you hear us talking about IOP, that means intraocular pressure, and it is not related to blood pressure. So how do we determine if someone has glaucoma? You may have to sit at a device similar to this, and you put your chin here, and there's a bowl, and it's almost like a video game. You see lights going off, and you press a button every time you see the light going off. And it tests your peripheral vision, and we check to make sure that you're not losing peripheral vision, because we say glaucoma steals your vision like a thief in the night. It takes the vision from the outside first so that you don't notice it so much. Now, this is a person with a normal visual field, and this is what a normal optic nerve looks like. And this is the cup. We always look at the cup to disc ratio. So this white area is the cup, this is the optic nerve. You can see here, this person has a little larger cup, and they have some damage here where it's dark. And this person, you see the cup is very, very large, and they've lost a lot of vision. We also do something called optic nerve scanning. And when I'm talking to my patients, I let them know that this test is sort of like a stoplight, where green is good, yellow caution, red not so good. So if you see a lot of yellow and red, that's caution. You see some yellow and red here, that's thinning of the optic nerve. And you can see here, this kind of looks like an onion ring. This dark part is the healthy part, the light part is the cup. And we prefer, when we take this scan, for it to look more like a donut or a bagel instead of an onion ring. I like to have a lot of food analogies. I like Okay. So I'm going to take a little break and see, do we have any questions on anything I've talked about so far before we go into retina? And I can't see the chat, so if somebody can just let me know if there are any questions or read any questions for me, I'll try to address them.
There are no questions in the chat at this moment, so I think if we can go ahead and get on through. As someone that's been wearing glasses since I was 7, you're scaring me, but okay.
I have a quick question. Can you hear me?
Yes, I can,
Yeah,
Mr. Thomas, yes.
Camera, but I have a question. As you can see, I hang out in the barbershops. And so here's my question.
Okay.
How might our barbers and stylists, if they were trained to either ask a question or to observe their clients over the years, what might they see that would give them a nudge to say to a person, you may need to go get your eyes checked?
I love that. barbers, hairstylists, I mean, they're kind of the hub of our community. And you might not notice something because you're generally, as a barber, you're sitting behind someone, but ask them if they have diabetes or if they have sugar or high blood pressure or glaucoma. And if they have any of those problems or issues, encourage them to see their ophthalmologist. That would be a fantastic thing to do. That would be fantastic. And I also, if you are a barber or a hairstylist, you want to make sure that your vision is excellent so that you do a good job for your clients as well. So if you start noticing that your vision is a little hazy, you know, you're moving back and forth, things like that, you may want to see an ophthalmologist yourself as well. I hope that answered your question.
Indeed. Thank you so much.
Okay, thank you. Okay, so now we're going to go on.
On your
Yes.
previous slide, there was a question, and I don't know which one, but there was a question about definition of the acronyms. I don't remember any acronyms on the last slide, but if you could go back there.
Which acronyms?
So the one right before your retina slide.
Oh, here?
Yeah, I
And
don't
that-
see it to define.
So my
It's the next
question,
one.
are there two types of glaucoma, doctor?
Oh, yes, there are more than two types. I just wanted to go over the most common, which is open angle glaucoma, but there is also narrow angle glaucoma, and your ophthalmologist will be able to tell you what kind you have. Far and away, open angle is most common. Now, when you look at your medications, sometimes people take cold medicine or antihistamines, things like that. It says if you have glaucoma, you shouldn't take this. That's if you have narrow angle glaucoma. And so I'll just tell you, this is the angle that we're talking about, the angle between the iris and the cornea. And we like that to be open. In some cases, it's more narrowed. And this is where the fluid drains out. So if it's more narrowed, you can imagine it's more difficult for the fluid to drain out. And any other questions?
There was another question in the chat about
Sure.
being able to do eye exams out in, I guess, settings without having to go into the doctor's office if you go to a health fair or something like that.
Oh, sure. Yes, I do health fairs all the time. And that's a screening tool, and it's okay to do that. But as we know, a screening tool does not take the place of a full exam, because the screening tool can just say, hey, they only screen for certain things. So they may screen for glaucoma, but you may have something I haven't gotten to yet, diabetes, diabetic retinopathy. So they might not be able to screen for that. So I think it's a good idea to use that to get an idea of how you're doing, just like I wouldn't use going to a health fair to take the place of seeing your primary care doctor. But it sure can be a good thing to do.
All right, I think we cleared the chat. We can move on to the retina and the other diseases.
Okay.
The last slide, just before this one, was the one with some, this one. I think
This
was
one?
the acronyms.
Oh,
The-
well, this is
ONH
something,
and RNFL.
yeah, all of this is stuff that we do. You don't really need to know about this, but this talks about optic nerve head, retinal nerve fiber layer. But the main thing I wanted to get across to you here is this is sort of like a stoplight. And this is a test that we would interpret, sort of like we would interpret an X-ray.
Okay,
Yes.
thank you.
Our NFL is not the Republican Football League.
You know what?
Well, I do like football, but I don't think it's that.
Well, your eyes are
Okay.
working very well, Dr. Maxey.
There
Yeah.
you go.
Yes, indeed. Okay, so now we'll get into the retina. And the retina is really important. The retina is like the film in the camera when we had the Kodak film, and we like it to be pristine. Remember how you didn't want to get, if you were on vacation, you didn't want to expose it to light, get sand on it, anything like that. And some of the things we're concerned about is macular degeneration, diabetes, and high blood pressure. That is very important. First, let's talk about diabetes. So as I mentioned earlier, you know, when you're the barbers, the hairdressers, you know, if you have diabetes or you ask your clients if they have diabetes, it's important for them to get their eye exam because they tend to get cataracts earlier. They're at increased risk for glaucoma and increased risk for retinal disease. Now, diabetic retinopathy is one of the major causes of loss of vision. We can treat it with laser surgery. We now have injections, but the only way you'll really catch it early is to have a regular eye exam. Now, I say you should have the eye exam every year, but if your ophthalmologist says, hey, I need you to come back sooner, you don't say, no, I already came back once. No, you come back as often as you need to. Sometimes you even have to come back every month with diabetic retinopathy. And we have to do a lot of testing to make sure, because as you can imagine, we're seeing in the back of the eye. So there's different things we have to do to be able to see in the back. So there are different types of diabetic retinopathy. And diabetic retinopathy is a disease of the blood vessels in the retina. And what happens is you can get leakage and you can get leakage of fats and oils that are normally in our blood vessels. They can leak out, and you see them in these yellow areas here. And sometimes blood vessels themselves can bleed. And you can see that here. Now, this area here is where you see the sharpest. So while this person has this not so good looking retina, maybe their vision isn't quite as bad as how everything else is. And maybe it didn't start here, maybe it started out here. So we need to look at you and examine you so that we know. And the key thing is, and this is actually why I became interested in ophthalmology, because you can look inside the body in its pristine state. And what I mean by that is I don't have to, spray water on it. Like if you, for other things, get a scope in the lungs, I don't have to cut you open or anything. I could just look and see how the body is functioning. And this gives us an idea of how the rest of your body is. So if this is happening in your eyeballs, the same thing is happening in your kidneys, in your heart, and other places. And we stay in close contact with your primary care doctor. And we say, hey, this patient has some diabetic retinopathy. We need to make sure that the rest of the organs are functioning. So this is what we call proliferative diabetic retinopathy. And you may be able to see these kind of tangle of blood vessels. They kind of look lacy. So what happens here is because I said earlier, sometimes the blood vessels leak and they're just not as healthy as they should. The retina, which is the orange part, doesn't get all the nutrients that it needs. So it says, hey, I'm hungry. I'm not getting my food. And it sends out a signal and it says, make some new blood vessels so I can get some food. And the body says, okay, I'll do the best I can. And it makes these new blood vessels, but they're not normal because you already made your blood vessels when you were developing as an embryo and a fetus. And these new blood vessels aren't so healthy. And what happens? They break, they bleed, they cause all kind of problems. So when we get to proliferative diabetic retinopathy, you know, it's more difficult. And we treat that, you know, again, with laser, sometimes other kinds of operations, but we'd like to see you sooner rather than later, so this doesn't happen. Now, with high blood pressure, I'm going to talk about that. I'm going to finish with retina, then we'll get to more questions. I see more questions in the chat. So with high blood pressure, you can have blockages. Just like when you have a heart attack, it's a blockage of the blood vessels in your heart. So we can get blockages of the veins, and that can lead to problems. But unlike your heart, I can look in the back of your eye and I can say, this person, their veins are looking narrowed or looking tight. I need to talk to their primary care doctor and let them know maybe they need to adjust their blood pressure medicine or something like that. So that's another good reason to go. Sometimes this can happen in the central vein. And if that happens, you get an appearance like this. And it's sort of like a, like if you have a water hose, you know, the hose that you water your garden with. Well, if you were to turn on the water, but then you were to clamp that hose, what's going to happen? Behind where you have the clamp, eventually all that water is coming out. And what happens? The hose is going to burst. So all the blood leaks out all over. And as you can imagine, that causes vision problems. We can work with you, but it does cause problems. Then, if the artery gets blocked, it can happen in a branch of the retinal artery, like the main one, or it can happen in the main branch. So a branch of the main artery, or it can happen in the main artery. And again, what happens? The arteries feed the retina, feed the tissue, it supplies, and it turns white. You see up here, there was a branch retinal artery occlusion. So this part of the retina died. In this person, their whole retina died because they had a central retinal artery. And if this happens, it's severe and we can't bring the vision back. This, we might be able to save some vision. But even if this happens, and I've had patients where this has happened, I tell them, well, I'm sorry that this happened to you, but this is a warning sign that you, are at risk for stroke. So you may have lost vision in one eye, but at least you didn't have a stroke. So, you know, your primary care doctor and everybody else has to work hard to get everything under control so that you don't have a stroke. Okay, so now we'll go back. Any questions on retina, what we just talked about? And I'll wait for you guys to ask me, please.
There was a question I think clarification, when you have the different source of pathology in the retina, whether it's venous or arterial occlusion or any of the patches from in the first slides. The question was, what impact does that have on the actual vision?
Okay, so here, this person would have some vision, but not all of the vision. This is the central part of the retina, this dark area. So this part up here would be impacted. This person would not see it all. They would see black, just black.
What about in the proliferative and the exudative?
Yes.
State?
So again, oh, wait a minute. Okay, so here, this is going to impact your vision because you're going to get swelling, what we call edema. So I don't know if you remember when let's say you look through glass, and I'm sure you guys have seen the glass that's like a brick. You know, sometimes people have it in their bathrooms so they can get light in, but you can't see in, like a big, thick piece of glass like that thick. So if you look through glass that's thick like that, you'll be able to see something. You may be able to see like a shadow. If a car is going across, a shadow of a car, you might not know it's a car, you might not know it's a truck, you might not know if it's a person, but you see something is going across. So you may have shadow vision, you may be able to see light. You may have, instead of 20/20 vision, like we talked about in the beginning, you may have 20/70 vision. So if you have 20/70 vision, what does that mean? That means your vision is not as good. And that means what a normal person could see at 70 feet away, you have to be 20 feet away. You have to be much closer. So this is the target, and this is 20/20 vision, and this is 20/70 vision. So a normal person could see it from here at 20/20. You have to be up here if you have 20/70 vision. So this will have an impact in your vision. And same here, this will have an impact in your vision. And what can happen here is if these vessels break, the eye will fill up with blood. And what will you see? You might see what looks like black rain, like a lot of black rain, not floaters. Floaters are like when you think you see a gnat and wave it away. No, you'll see like, it looks like black rain, and part of your vision may be compromised. We can work with you again on that, but we'd like it not to get to this point.
So
Thank you.
Dr. Bovell,
Yes.
there was another question in the chat related to changes in eye health when a person is told that they're pre-diabetic as opposed to having a diabetes diagnosis.
Sure. Thank you. That's an excellent question. Your body doesn't really know the difference between pre-diabetic and diabetic. It's sort of like on a continuum. So if you're pre-diabetic, you need to get your eyes checked because we may be able to see some things that aren't quite manifested in your blood work, and it gets you in the habit of seeing. Now, I will say this. If you are pre-diabetic, I think somebody was talking about this earlier before we started, the best thing to do, even though it is hard, is to eat right, see a nutritionist, and be like Dr. Walks. And you don't have to run the marathon like him, but if you can just do some exercise, it doesn't mean you have to go out and do the whole exercise, run a marathon in one day, but just walking, any kind of exercise helps with diabetes and helps with these problems. That is the best thing to do, and to see a nutritionist. And if you're pre-diabetic, you know, the thing to do is to start changing your eating habits. Maybe not have dessert every single day, maybe just have it once a week so that you can continue to enjoy dessert once a week for the rest of your life instead of, I can't eat dessert anytime. But the most important thing, if you're pre-diabetic, it's not to say, I'm okay. And all of this, people say, oh, I'm not claiming that. Well, you might not claim it, but your body is on the way to claiming it. So that's not a good thing to say. The good thing to do is to act on what your primary care doctor has told you, and ask your primary care doctor for nutritionists. And a lot of primary care doctors now have implemented nutrition programs into what they do, and that is the best thing to do. Yes. Okay, sorry, that's one of my soapbox issues.
That's good.
Anything else?
Well, we have a lot of questions about cataracts that have been popping
Oh,
up.
we're going to get to that. We're going to get to that. Then we'll have to have Dr. Walks talk to us about exercise, right? Okay. Talk
And
to
we're
me
going to
too.
have you back to talk. There's a lot of
Right.
interest in the information you're sharing today.
Right.
Oh,
Right.
okay. So, you know, I talked about the jelly-like substance in the eye. That's this vitreous. When we're first born, it's like the consistency of a raw egg white, sticky like that. And then over time, it becomes more watery, and it sort of does the opposite of Jell-O. You know, when you make Jell-O, you put the water and the packet in the water, you stir it around, it gets thick. Well, this does the opposite. It becomes thinner, and you can see all these, it becomes less thick, and you see these clumps. And like I said, sometimes you may think you see a gnat or something. That's a normal thing. If it happens with flashes and floaters, I mean, flashes of light, like a neon light or a lightning bolt off to the side, then let your ophthalmologist know. So, oops. Okay. Okay. Oh, I'm sorry. This is sort of on a, I don't know why it's doing this. So, why is it going? So we're going to talk about cataracts here. Okay. Cataracts, let me see if I can go back to pause. Can you still see that?
Yes.
Yes.
Okay, so a cataract is the clear lens, and it can become frosty. Do you see this picture where I'm pointing here?
Yes.
Yes.
Okay, good. So this is what becomes a cataract. The good thing, it's reversible because we can do cataract surgery. And then we're going to go into that. And not sure what happened.
We're seeing cataracts and symptoms, so now it moved again.
Okay, so I'm going to show you this. So what happens with cataract surgery is, this is the cloudy lens. We remove this, we make an incision here, we suck it out sort of like a vacuum, and we replace it with a clear synthetic lens. So it's like looking through a dirty window. This is like looking through a clean, clear window. Can you see that?
Yes.
Yes. Okay. Good. So now what I'm going to do is talk about some of the different kinds, those lenses I mentioned. We're going to talk about some of the options. You can have a regular monofocal lens, which allows you to see at one distance. So you can see out in the distance. but it'll be hard for you to see on the computer screen and read. But now, the good thing is with cataract surgery today is we can give you a multifocal lens. So that means you can see up close, like reading a menu, work on your computer, and have good driving distance. And this is kind of what that looks like. I'm going to start this up again. All righty. So here, this person has a multifocal lens. So they can see in the distance, up close, and also they can see the menu. Here, this person has a monofocal. And it's sort of like if you have your glasses, right? You have bifocal glasses and you have single vision glasses. So it's the same thing, except we're able to put that in your eye. Okay, so now the next thing, the next innovation that we have is laser cataract surgery. Before it wasn't done by laser, but now recently it is. So we now have the ability to be very precise. And as good as my hands are, my hands cannot reach the precision and approach the precision of a laser. So when we use the traditional surgery, we make the incision with a blade. If you get the laser cataract surgery, the laser makes that incision. And we make the opening in the front of the lens, it's called a capsular rhexis. Here, the laser makes that. And then we use an ultrasonic equipment. Like I said, it's sort of like a vacuum to break apart the cataract into smaller pieces and suck it out. Here, the laser breaks it into smaller pieces, and then all we have to do is suck it out. Now, the things that are the same, we put in a lens. We do that manually. But the other thing we're able to do with laser cataract surgery is correct for astigmatism. So that's going to give you sharper vision as well. So that is it for now. I know we have some more questions, and I'm happy to answer questions that you have.
I'm going to ask you one of the first questions, Dr. Bovell. First of all, thank you for that excellent talk. And I was taking notes. But can you explain and define for our audience what are the different types of eye doctors and what do they do? I know there's an optometrist, there's an oculist, there's an ophthalmologist. Can you just, because many people come to me and they've gone to an oculist and said, I went to the eye doctor. I said, no, you didn't.
Yes. You know, it's hard. They all begin with O, okay? So I'll start with the ophthalmologist because that's what I am. So the ophthalmologist, just like Dr. Naybert Stevens, Dr. Maxey kindly gave my introduction. I am a medical doctor, just like a lot of you are here on the talk. So what does that mean? Just like all medical doctors, we go to college, then we go to medical school. We either graduate from medical school either with an MD or a DO, which is Doctor of Osteopathy. Doctors of Osteopathy, same as medical doctor. They're both doctors. Then, just like some of you went on to specialize in internal medicine or orthopedics or family practice, I decided to or radiology, right? I decided to specialize in ophthalmology. So I, just like my colleagues here on this talk, I went through medical school, learned all about the human body, how drugs and general surgery and all that interacts. And then I did my specialty in ophthalmology. And then just like some of you have decided to do internal medicine, then you said, I want to specialize even further in cardiology or pulmonology or nephrology. I did a further specialty in cornea. So with optometrists go to college, then they go to optometry school. So they don't go to medical school, and optometry school is 4 years. Some of them may elect to do an extra year, but it's not the same. It's not the same amount of years of training. And we work hand in hand with optometrists. Optometrists are generally the people you go to when you need contact lenses, when you have glasses, you need a new glasses prescription. But if you have a medical condition, the best thing to do is to see a medical doctor and surgeon. And then the other thing is an optician. The other specialty is an optician. Opticians have expertise in making the glasses. So I'm picking on you, Dr. Walks. So I see that you have your glasses on. So an optician is the one who may look at your glasses, measure your pupil distance, make sure that you can see, distance, near, up close, and make sure your glasses are well made. I hope that's helpful.
Okay.
Generally, an ophthalmologist works in their own private setting or at a university setting. And if you don't know, if you're seeing somebody, ask them what degree they have, because everybody is called a doctor. So if they say, I'm a doctor, you want to say, are you an ophthalmologist or an optometrist? And generally, an optician will not examine you. But if you want to know the difference, ask, are you an optician or an optometrist? And that should clear things up. And an MD like Dr. Maxey has MD after his name, or he may have DO after his name. An optometrist will have OD after the name.
Thank you so much. That was very clear.
Okay.
Are there any other questions, Dr. Neighbor Stevens and Dr. Walks?
There are a bunch of questions. There was a question
Go
about,
right ahead.
Dr. Gasson wants to know about macular degeneration. And
Yes.
Another question is, are transition lenses protective? So
Is that
go with
Dr.
those
Sandra
two,
Gadsden
come
from
back.
Indiana? Would
Yes.
you unmute her and let her ask her question for a moment, Dr. Gadsden?
Hers was the macular degeneration question.
Can you unmute her for a moment?
Yes, I can talk about macular degeneration.
Dr. Gadsden? Maybe she's
Yes.
muted?
I'm unmuted, I think. Yes, Dr. Max, hello.
Hello, my fellow nephrologist from Indiana.
Hello, sir. I wanted to say this has been a very good discussion, and thank Dr. Bovell for a wonderful presentation. But I
My
did have a question about macular degeneration, and is it treatable?
Yes, it is treatable, very treatable. And, I like to tell my patients, if you have a problem, any kind of a problem, whether it's a kidney problem, high blood pressure, whatever, this is the best time to have that problem because we're always coming up with new treatments. So there are just in these past couple of months, there are 2 new excellent treatments for macular degeneration that we didn't have before. They are injections And don't be scared if you have to have it. I know we used to say, cross your heart, hope to die, stick a needle in your eye, right? Sometimes we have to do that. And the medications do help. The other thing that we've known for 15, 20 years maybe, is certain vitamins do help with preventing macular degeneration. And, you know, we used to be told that macular degeneration occurred primarily in Caucasians, and African Americans didn't have to worry about it. Well, that is not true. My practice is largely African American and African, and every single day I see somebody that looks like me that has macular degeneration. And I'm always a little bit like taken aback because I'm like, this isn't what I was taught, but it happens. So, but yes, there is treatment. And what you should do, there's something called an Amsler grid, and it looks like graph paper. And you can, and it has a little dot in the center. I can try to find that and show it to you. And if you look at that every day, all the squares, you know, when you look at graph paper, you have the squares. All the squares should be even, just like they are. If you start to see wavy lines or a shadow or a missing line, then you have to let us know.
Okay. All right.
Thank you so
Mhm.
much.
Thank
Dr.
you.
Gaston is also a past president of the National Medical Association. So
Mhm.
Well,
Yeah.
of course, we thank her for all she's done, 100%.
Okay.
So are transition lenses protection enough against the UV rays of the sun? And incorporate in that a comment, if you will, about the need to, or lack of need to protect your eyes from the sun.
Sure. Well, wearing sunglasses, the polarized sunglasses, is the best protection for the sun. And if you're going to be, even if you're, like I'm in DC, so just going out, especially in the summer, I wear sunglasses. Now, if you're in a place where it's really reflective, like the lights reflecting off the water or even snow, you know, there's such thing as snow blindness, snow, or the sand on the beach, you definitely want to wear sunglasses, UV sunglasses. If it's not too bright, you're not going to be out for a long time, the transition lenses are okay. But this lady here, Hazel Tanner, her picture, those glasses, they look pretty dark, and those look good. I don't know if they're polarized or not, but something like that looks good.
Dr. Neighbor-Stephen, anything else in the chat? Dr. Walks?
There are other questions. One of the questions is about whether cataract surgery or both types of cataract surgery are covered by Medicare.
Sure, that is a very good question. The first type that I mentioned, the traditional type, is covered with your Medicare. Using the laser is not covered by Medicare, so you will have to pay extra. Part of it is covered, the regular cataract portion is covered, but the work that the laser does is not covered. Because why? Well, Medicare feels that that is more cosmetic, even though it's better. They feel that it's more cosmetic and that you can be just fine with wearing glasses.
So I have 35 questions as someone who has suffered a vitreous detachment, who has worn glasses since he was 7, who knows cataract surgery is coming up, with a family history of glaucoma. So I have to call your office and make an appointment. And my
Yes,
wife
sir.
can come in and make sure I pick out glasses that she likes because she hates these. So I think, but I think the main question I have, and maybe this goes back to what Dr. Thomas talked about, is it is just, is it important for all of us to just be thinking about our eyes? We don't think about our eyes a lot. We just open them and start our day. And so what would be some just routine eye care recommendations you would have for someone that I'm getting up, I'm just starting my day. What should I be doing to protect my eyes?
Excellent question. First of all, everybody 45 and older should see an ophthalmologist once a year, at least, just like a routine, just like you get a regular routine checkup. Now, we all have, fancy cars, the Lexus, the Mercedes. You take that car in every year or every however many miles, 3,000, 5,000 miles, you got to treat your body the same way, just as good as your car. Okay. Now, what kind of things should you be doing? Well, looking at the computer screen, if you can make the light a little dimmer, or sometimes they have a night screen display so that it's not so bright, especially if you have a job where you're on the computer 8, 10, 12 hours a day, or your cell phone 8, 10, 12 hours a day, then you can do the same thing on your display. So decreasing computer light. Or if your eyes really bother you, you can get a anti-glare screen, and that will help. When you're on the computer, there's a 20-second rule. What is that? 20, 20, 20. About every 20 minutes or so, look away for about 20 seconds, look out into the distance, kind of relaxes your eyes a bit, and then come back to going to looking. If your eyes are feeling irritated, you can use over-the-counter artificial tears. If you have to use those tears more than 3 or 4 times a day, then you should see your ophthalmologist to figure out what's going on. Are you having dry eyes? Is something else going on? And what I'd like to say is, like Dr. Walk said, you open your eyes, you should go about your day. If you start to notice your eyes, like you have to rub them a lot, or you're blinking a lot, or you go and get your glasses, and then 2, 3 months later, like, these glasses, they don't seem as good anymore. That is a sign that something may be going on, and we have to check. Now, I am gonna talk to the women. We all like to enhance our beauty. We have to be careful with makeup, especially nowadays with the eyelashes, right? The fake eyelashes. Be careful of where you go. If you go get them at the nail salon and they're putting them there, how clean is that? And are they using the same tweezers on me that they use on the next person and the next person and the next person? And if they're putting the glue, are they really sterilizing that? And you have to be careful, because there are glands around the eyelashes called meibomian glands. They secrete an oil. That oil is necessary so that when you blink, your eyes are naturally coated with this oil. It's sort of like the consistency of olive oil. when those glands get clogged, it can become more like toothpaste. So sometimes we tell people use warm compresses each morning to kind of make sure those glands are being, the oil can come out. But I don't really like the eyelashes. Now, there are some magnetic eyelashes that you can put on yourself that is better. Maybe that might not look as fancy as these individual ones they put on. But I think mascara is good. I wear mascara. And I don't have a interest in this, but I like the Blink, BLINC mascara. It has these little tubules and it makes your eyelashes look really, really long. So, and you can experiment with different kinds of mascara, but I'm not a fan of wearing the eyelashes all the time. If you have special occasions, maybe. But I'm just not. Yes.
We're at the past the top of an hour, and I'd like to thank you so much for giving your time. I have one last question before we get final comments.
Sure.
What is the relationship between the quality of your eyesight or lack thereof and cognition?
That's an excellent question. I'll tell you, a friend of mine who is a physician, she called me some years ago and she said, you know, my mom isn't doing so well. She used to be active. And then she slowed down. Then she just watched TV. Now she doesn't even watch TV. She'll just listen to the radio. And she thought her mom was getting dementia, Alzheimer's, something like that. And I said, how old is your mom? Her mom was, I don't know, 80-ish, 70, 80, something like that. I said, has your mom had cataract surgery? She said, no. I said, your mom has cataracts. Take her, and I didn't even examine her mom. Her mom lived in another state. I said, take your mom to get cataract surgery. She did that. She said after the cataract surgery, her mom perked back up. She was out, she was active, she was doing things. Sometimes people have vision problems, but they can't articulate that they're having vision problems. And if you with the cognition, if you're even in young people, in kids, your kids need to have their vision checked, because if they can't see the board or the whiteboard that they use now, and they're trying to learn how to read, they're not going to know what's going on. They're not going to be able to see, and so they're going to not learn as well. Then, you know, kids, they're going to act out because people are talking about things. They're not going to understand what they're talking about. And then they may be disruptive, and then they're labeled as this, that, and the other, when really it's just that they may need glasses. And the same thing with us, and our parents, if you can't see, your world becomes smaller, and you tend not to interact as much. And you may not know, you may say, no, I'm not going to go out to dinner with my friends. It's harder for me to see. I don't feel comfortable driving. And then you just stay in. So that was an excellent question. Thanks, Dr. Maxey.
Thank you. Would you have any final words before our moderators give theirs, Doctor?
Well, as you see, I'm very passionate about vision. I can go on and on. But the main thing is that you should not be aware of your eyes. If your eyes, and this is any part of your body, pain and irritation is your body's way of talking to you and telling you that something is wrong. Don't ignore it. If you're having blurred vision, irritation, anything like that, please see your ophthalmologist.
Well, thank you so much, and I hope you will come back and join us again in the near future. Dr. Walks, do you have any final thoughts and comments?
Thank you, Dr. Maxey. Dr. Bovell, thank you so much for being with us. Your your expertise and the way you normalize and deliver the information so that it's useful for the layperson is really something that we can all do better. I think that I was at a health fair yesterday talking about health and about normalizing conversations about health. And I think it's important for us to recognize that we can ignore any part of our health, but if we are too busy, we'll be forced to take time to deal with it. When your vision disappears or dissipates, you'll be forced to do things slower and slow down. So I just want to encourage everyone to take the information today and really pay attention to your eyes. Something you may have thought nobody could fix 5 years ago. Every time I go to the ophthalmologist, there's some new piece of equipment that I don't recognize. There's some new fancy thing that they can do that nobody thought that they could do. So there's a lot of opportunity for us to be able to see better. I'm going to get some of those new lenses because it sounds like I can get rid of my glasses. I can get rid of my astigmatism. I can get some of those cool looking sunglasses.
And
If I
stay
get
away
the
from
right
those
lens.
eyelashes,
All right.
Dr. Walks.
I'm not getting the eyelashes, Dr. Max. No.
Dr. Neighbor Stevens.
I just want to express my gratitude to our speaker today for giving us the information that we really need. And there's much more than that we need. And I look forward to her clearing her schedule at some point in the near future and joining us again, because there are a lot of things yet that we could talk about, like why you wear glasses and when should you start, and all kinds of stuff like that. And on a serious note, I want to say that as we go through the summer months, and some of us may be traveling or we're having family gatherings or whatever you may be doing during the summer, be careful. There are so many things going on now that are not the norm. And I'm not going to get political, but I think we need to be careful. Maybe it's because I live in Florida that I'm feeling this, but please be careful.
Well, thank you, Dr. Neighbor Stevens. Is Dr. Davis on the line? Helen Davis, by any chance? Do you see her, Simon?
I do not see Dr. Davis.
Okay, she's our resident ophthalmologist. I thought she might have a comment, but thank you again so much, Dr. Wovell. This has been excellent. And all of us are desirous of you coming back again and doing another talk on ophthalmology. And we thank everybody. Simon, thank you so much. Thank you, Dr. Neighbor Stevens, Dr. Walks, and thank everybody. Have a great, great Sunday. Good afternoon.
Good day, everyone.
Thank
God
you.
bless you.
Thank you.